Good morning, good afternoon, and good evening. My name is Hazim Al-Momani. I'm a consultant bariatric surgeon based in Abu Dhabi, the United Arab Emirates, and it brings me the greatest of pleasures to welcome you to the 19th IFSO webinar. With us today, all the way from India, we've got Dr. Praveen Raj to talk to us about his recently published randomized controlled trial in obesity surgery, which talks about the comparison between the enhanced recovery and the traditional recovery pathways after laparoscopic sleeve gastrectomy. Dr. Praveen Raj is the head of the Department of Surgery, Division of Gastrointestinal Surgery at Jim Hospital and Research Center from India. Dr. Praveen, thank you very much for taking the time to talk to us today. So without further ado, I'll leave the stage for you to talk us through your paper, and we'll catch up later to go through the questions and answer any of the questions the audience might raise.
So thank you, Hazim, for that wonderful introduction. Okay. So I think no better time for an IFSO Journal Club than now. I think although IFSO has been doing this wonderful journal club for a long time, I think this is probably the time that a web-based webinar makes more sense. And I'm really happy and privileged to be presenting our paper, our work from India on this subject, enhanced recovery pathways. And I hope everyone around the world are taking care of themselves, staying safe. And I think, yeah, we have a new way of living. I think probably this is where they're going to be, that we have to meet each other more virtually, even start finding ways of socializing with each other virtually. So without spending much time, I would straight away go on to my presentation. So which will be on the randomized control trial comparing enhanced recovery pathway and standard recovery pathway for laparoscopic sleeve gastrectomy. I'm Dr. Praveen Raj. I head the Department of Bariatric Surgery, Gem Hospital at Coimbatore and Chennai in India. At this first, I would like to thank my entire team for making this work happen, for their long work, the long effort that they've done, and happy to share our work. We do not have any disclosures at this point. So to introduce, enhanced recovery after surgery was first started as a first track surgery. Basically, as you all know, it was started for a colonic surgery or colorectal surgery way back in the early 90s to enhance the recovery of the patients and to improve the outcomes of the surgery. It was only after this that we started to realize the outcome of surgery is just not about doing a good surgical procedures as such, but a series of perioperative interventions, starting from the preoperative setup, intraoperative setup, which does not just mean surgery, which we surgeons are spending most of our time are breaking our heads, but in doing a lot of protocolized steps in the intraoperative setting, other than the surgical work, and postoperative management. So the primary aim or the main aim of this enhanced recovery is to maintain physiological function without having a deterioration of the physiological function, enhance mobilization, reduce pain, reduce perioperative surgical stress, starting early nutrition, eventually trying to achieve an early recovery, which could possibly translate to reduced morbidity. I mean, not just a physiological morbidity, but a psychological morbidity, which patients fear towards in having a surgery done. So enhanced recovery after surgery, the pathways have resulted in reduced morbidity, faster recovery, and reduced length of stay, as the name clearly defined. So we all have been doing an enhanced recovery pathway or the protocol some way or the other in our everyday day-to-day practice. So what is the ERAS pathways and what is standard pathway has actually been a very gray area, because we've been doing something or the other on a regular basis. And the ERAS Society has clearly defined and routinely implemented centers and have clearly said they're implementing these protocols have improved perioperative outcomes even in bariatric centers. So this has been clearly shown. And the ERAS Society guidelines have also been published as a consensus statement, but it's only a consensus statement by experts in the year 2060. A lot of the protocols are yet to be defined because this was more of a consensus statement, which is more like a level 5 evidence. When we talk about level 1 evidence, we do have only 2 randomized control trials on this subject, particular to bariatric surgery. Only 2 randomized control trials that have been done. And we have 1 systematic review of literature and a meta-analysis on the same subject that was published last year, which have finally concluded that enhanced recovery pathway protocols are safe and are feasible in bariatric surgical practice, and implementing these protocols have reduced hospital stay. But when we try to go back and try to understand what is the research gap, we try to do a research gap analysis of these papers that have already been published. What we found was the pain score was not compared in these subjects altogether. A multimodal analgesia, especially in the form of a transverse abdominis peritoneal block, in the form of what we call the TAP block, was not used. The pain pathway itself was not clearly defined, and no standardized conventional pathway was obviously defined. So there was no clear-cut control group that was defined, but then there was kind of a gray area. This wasn't properly defined. So this was the gap that we found when we tried to do a research gap analysis of these existing data. So it was based on this that we tried to define a randomized control trial. We got it registered, which was a trial that compared enhanced recovery after surgery versus standard pathways for sleeve gastrectomy. The sample calculation required us 56 patients in either of the groups. So we had about 2 groups. One was ERAS pathway standard with 56 patients in either of the groups. 112 consecutive patients were taken in a randomized method. So we chose a closed envelope technique for the randomization. The patients were excluded were ASA 4 or above patients, redo surgical patients, and patients where we combine procedure. We are a center where we do a lot of combination of mesh repair along with bariatric surgeries, including sleeves and the bypass. We have published our series 2. But these patients we have excluded as that could have a confounding effect on the final outcomes. So the primary outcome that we were trying to look for was the hospital stay. Secondary outcomes that we were trying to look for was the pain score, the analgesic usage, the post-operative nausea and vomiting, time to ambulate, and time of starting oral fluids. These were secondary outcomes. So the ERAS principles and protocols required in the preoperative setting, the most important step was the counseling to the patients about the concept of because this is probably the most important aspect of an ERAS, which is probably not given too much of an importance, because the patient needs to be looking forward what is going to be happening in the immediately post-operative period, because that understanding helps in their recovery. Because it should not be a shocker to them. Oh, you got to be doing this now. Oh, you got to be doing that now. If this information and counseling and the familiarization of the processes needs to be explained to the patient is an important aspect of the preoperative pathway. A low-calorie diet, I think, which is followed in most of the centers. We do have a lot of evidence supporting that. We follow 600 to 800 low-calorie diet for a week prior to surgery. And we give a dexamethasone injection. A lot of time, the anesthetists give this dexamethasone at the time of the surgery or during the induction process. But it's very important that this is given 90 minutes before surgery, because it takes about 2 hours roughly. This is a long-acting steroid. It takes roughly about 2 hours for this to act. And we give clear liquids 2 to 3 hours preoperatively, but many of these studies have defined you can give a carbohydrate loading in the form of a maltodextrin also can be given, which is not available in India at this point. So we tend to give a tender coconut water 2 hours prior to surgery as a carbohydrate loading. So this is what we done preoperatively. Intraoperatively, the protocols include restricted intravenous fluid. So 4 to 6 ml per kilogram per hour is what we follow. So normally it is actually about 8 to 10 ml per kilogram per hour is followed. So basically we try to restrict the fluid as per the need to avoid any kind of a fluid retention. For the post-operative nausea and vomiting prevention, we give ondansetron half an hour before extubation. Dexamethasone, as already explained, 19 minutes before induction. Propofol is the preferred induction agent. And we try to use nitrous oxide as a carrier gas. And the anesthesia management, of course, there's more from the anesthesia standpoint. In fact, my colleague, my anesthetist, Dr. Prabhakaran, is beside me to answer any questions. Fentanyl is given at 1 to 1.5 mics per kilogram. We're actually working on a study where we are trying to do a non-opioid anesthesia also we are looking at as a study, because opioids have the respiratory depressant effects. If we can possibly avoid that, that also would make good sense. And desflurane is the preferred anesthetic drug. MMA, a multimodal analgesia in the form of a tap block, which is transverse abdominis plane block, is given as a routine in all these patients. The 4-quadrant block, I'll be explaining that a little later towards my discussion. And of course, intraoperatively, which all of us are very quite familiar about, always it's laparoscopic. A thorough peritoneal wash with normal saline is very important to suck out all the clots. So, sometimes the carbon dioxide stays with the blood, forms carbolic acid, which can cause pain, diaphragmatic irritation and pain. So good wash is important. A known nasogastric tubes are there, and we try to avoid drains. Of course, drains, if mandatorily required, let's say there's a lot of oozing and etc., then drain is put, but drains are almost always not used. Postoperatively, the postoperative analgesia, we have a stepladder pattern of analgesia, where in the first level it's IV paracetamol given 6th hourly. The rescue analgesic is a barbiturate, but a low barbiturate in the form of a tramadol, or an NSAIDs in the form of a diclofenac. Suppository or an IM injections can be used. A thromboprophylaxis is given in the form of a compression stockings. Chemoprophylaxis is mandated. We try to do a mechanical and a chemoprophylaxis together. So enoxaparin is given. We have a dosage of 0.4 BD for less than 100 kilograms, 100 to 150 kilograms, 0.6 BD, and over 150 kilograms, 0.8 BD. And we try to ambulate as soon as possible once the patient is awake. That is roughly 2 to 4 hours after surgery. And postoperatively, we try to start clear liquids as soon as the patient is conscious, well oriented, 2 to 4 hours after surgery. We try to stop IV fluids on the post-op day number 0, making sure the patient is tolerating enough oral liquids. In diabetic patients, the blood sugars are maintained around 150 milligrams, and long-acting insulin is used, and we do have a lot of data that supports long-acting insulin against the sliding scale insulin. And oxygen individualized to our OSA and non-OSA patients, depending on the saturation, depending on the breathing capacity, depending on their ambulation. CPAP as appropriate, as much as possible, we do not use it unless in an obstructive sleep apnea patient in whom carbon dioxide is rising or saturation is not able to be maintained. And we try to start incentive spirometry and deep breathing exercises as soon as the patient is awake and the patient is oriented. So this is that is something different compared to the other pathways, wherein we wanted to define the standard pathways also, because many times in our practice, we keep using bits of that and bits of these. So we really do not know what we are doing is ERAS pathways or standard pathways. So in our paper, we define the standard pathways, wherein again, information and counseling not about the standard pathways, but in general is given. And we do an overnight fasting. Liberal IV fluid therapy, this is what most of the anesthetists do, is roughly 7 to 8 milliliter per kilograms per hour. Opioids are routinely used in the form of fentanyl. Of course, we do not follow a tap block as I described earlier to you. Of course, we do a port site infiltration at the end of the procedure. We use a nasogastric tube as in followed in many of the centers in Asia and around. But then if this is to reduce the retching in the postoperative period, because most of our centers, there is a lot of oncologic work that happens wherein nasogastric tubes are routinely used. But this is used for a few hours, maximum for a day, unless the patient is tolerating it. If the patient is not tolerating it, this is removed. Drains whenever necessary. And the post-op analgesia also, we try to give NSAIDs and opioids as a stepladder pattern. Thromboprophylaxis as what we use in the ERAS path, which I explained to you. But we do not encourage much of liquids on the post-op day number 0. We might be giving sips of liquids, but the clear liquids as such is started on post-op day number 1. And restricted ambulation, the patient, if willing to ambulate, he might ambulate on post-op day number 0, but a proper ambulation would start only on the post-op day number 1. So this is what we call the standard pathway. So this is like the case and the control. So this standard pathway favors the control on which we will be comparing our ERAS groups. So the discharge criteria will be there should be adequate pain relief, not requiring any kind of an analgesia, especially non-opioid analgesia. No evidence of any wound infection or wound dehiscence. No other postoperative complications. The pulse rate is within 90. Temperature is normal. The respiratory rate is less than 20 breaths per minute. And the procedure was an uneventful technical procedure. Patient is ambulating well and tolerating 1 liter of clear liquids over a period of 24 hours and tolerating free oral liquids where the discharge criteria. So we try to define exactly at which point the patient meets the discharge criteria. So based on this, the documentation would be done. So going to the results, if you actually look at it, the preoperative parameters between both the groups are comparable to each other. So be it the age, the sex, the weight, the BMI, presence of comorbidities, especially the ASA. So ASA 3 and above were excluded. It was ASA 1 and 2 were the patients that we were included in our study. So intraoperative characteristics, what is very important to note is that the operating time was higher, significantly higher in the ERAS group. It was 65 minutes against 58 minutes in the standard group, which was obviously directly linked to the extra time that was needed for the TAP block, because the TAP block required, of course, in the beginning, when we did a pilot study, it was much more, but then on average, it takes about 7 to 10 minutes for the TAP block to be done by even by an experienced anesthetist. There was no difference in the blood loss. However, the IV fluid usage was significantly lower in the ERAS group as against the standard group, where roughly about 1100 ml of fluids was used for the entire surgical procedure for the ERAS group as against the standard group. In the post-operative setting, if you can see, all the parameters were significantly better in the ERAS group. The time to ambulate, which was 4 hours in the ERAS group, is against 8 hours. The pain score was significantly lower in the ERAS group. This was significant. This was exactly at the 4th hour and the 8th hour where it showed statistical significance. Even in the opioid usage, if you can see, the requirement for tramadol and fentanyl was significantly lower in the ERAS group as against the standard group. However, there was no significant difference. Although it was lower in the ERAS group, it did not achieve statistical significance with regard to postoperative nausea and vomiting. The hospital stay, again, which was a primary outcome, was significantly lower at 1.3 versus 1.9 in the ERAS versus the standard group, and there was no 30-day readmission rate. And when we did multivariate analysis, the functional length of the hospital stay in the ERAS group was significantly affected by the average pain score. So it's obvious that the pain score that is most important that we need to be looking at in addressing our patients. So coming on to the discussion. So from our study, we understand that it's very important a good preoperative information and counseling as a part of the preoperative protocol is a must. And with regard to the anesthesia, no prolonged fasting is really required. A clear liquids can be given 2 hours, even up to 2 hours preoperatively. And if you have access to the maltodextrin carbohydrate loading, that can be given 2 hours prior. Although we do not have any strong evidence to support, but most of the guidelines have recommended these. Restricted fluid therapy is very important. Avoid nitrous oxide and use air as a carrier gas. This is something which you can discuss with your anesthetist, because many times anesthetists prefer nitrous oxide. Short-acting inhalational agents like a desflurane is probably the anesthetic drug of choice for maintenance of anesthesia in the morbidly obese patients, as we all know, although it comes with a cost. Reduce the opioid usage as much as you can. Of course, if we can design some way or the other where we can avoid opioid usage to the minimum, even if you can avoid, that will even make difference. But then in this study, we have tried to ultrasound guided TAP block has a significant impact in reducing the postoperative pain, and a recruitment maneuver as a part of the anesthesia is important as part of it. So this was the multimodal analgesia which I was trying to explain to you. A TAP block is something if you can request your anesthetist or your radiologist to be, because here in my case, my anesthetist who gives my primary anesthesia, who's the principal investigator, does this entire thing. So what we do is a combination of a subcostal block and a posterior block. The subcostal block basically addresses the areas, the dermatomes of T7 to T10, wherein we primarily put our ports on bilateral sides. So that will take care of your port-related pain. Your posterior TAP block will take care of your pain which is arising because of your stretching of the parietal peritoneum. So under ultrasound guidance, it is between this internal oblique and the transverse abdominis muscle that you try to gain access, wherein you infiltrate bupivacaine on both sides, including the posterior. So what we call the 4-quadrant block, that is very, very important in these patients. So basically you mix ropivacaine 30 ml along with the distilled water of 30 ml, or you can combine bupivacaine 30 ml with the distilled water of 30 ml. So this is what we do in the TAP block. So it's basically a combination of a subcostal and a posterior block on either side, which is what we call the 4-quadrant block. Of course, if you can work with your anesthetist, they will be the best person to get this done. However, in practical issues, patient compliance is something that's quite difficult that we need to work upon. So that is where counseling becomes very important. Many times there is a difficulty in ambulation, some drowsiness, some giddiness, pain, may restrict patients from going out. The most important aspect to be addressed is the post-operative nausea and vomiting that we need to look into. So that is where the combination of drugs, which I spoke to as earlier, ondansetron 30 minutes before extubation, dexamethasone 90 minutes before induction, and a combination of a propofol for induction will help in reducing this post-operative nausea and vomiting. But this is something we as a team, from preoperative, from our coordinators to your intensivists, to the staff nurses, to the surgeons, to the anesthetists, need to work in tandem along with the compliant patient. Only then we will be able to get the right kinds of outcome that we're looking at it, because it has its own practical difficulties, which we can discuss during the question and answer session. So then you need to have protocols that is established at every single level. Even at one point, if it is broken, then the entire process gets broken. So we need to have a proper clinical pathways and a multimodal intervention, a multidisciplinary approach is very important to address this aspect, with patient being the center of the entire process. So to coming on to the conclusion of my study, ERAS pathway significantly reduces hospital stay and pain with no increase in morbidity. However, requires a committed team and a committed patient. That's very, very important. Although tab block increases the operative time, it adds to the benefit of the ERAS. So your operating time is slightly going to go up. Yeah, the logistics and the cost of it, you need to work with your colleagues. And the ERAS pathways can be routinely followed from sleeve gastrectomy. Of course, you can translate it to Roux-en-Y gastric bypass. So that is another study which is ongoing, which should be coming out soon. But more importantly, other than all this, if you really ask me, it is just not about the hospital stay. Taking the learnings out of this, we can have a translational benefit to higher risk patients. Let's say, for example, an ASA3 patient, a patient with a coronary artery disease, with a severe obstructive sleep apnea. We're taking these protocols onto them by reducing their pain, by helping them recover early, by making them ambulate quicker. We can reduce the potential atelectasis that can happen, reduce your hospital stay in the hospital stay, reducing secondary infection from others. We can reduce the overall morbidity on the high risk patients. So my learning from this entire study, more than actually trying to show ERAS reduces the hospital stay, it has a translational benefit in higher risk patients. This pathways makes you approach a higher risk patients much easier, much better. Your team is much more, and then you can give a much better outcome, is the learning that we have had from this study. And I think that is what we need to look into, applying the ERAS concept on higher risk patients. How are we going to look at it is what something I think we do not have a study yet, which is what something we're trying to work at. Possibly we'll be able to come to you as soon as possible. Until then, stay safe, take care. We will all tide out of this situation as soon as possible. I hope we will all see each other, not virtually, but somewhere in the world, some point of time we'll be able to work with each other. Thank you all for your patient listening, and hope it was a useful presentation. Over to you, Dr. Hazem.
Dr. Praveen, it was a very useful presentation. Thank you very much. I enjoyed listening to that. If you don't mind, just keep your camera on. To all of you audience listening to us, we would like to thank Dr. Praveen for this excellent talk. Please keep your questions coming, as we will take any questions from the audience now. If you don't mind, Dr. Praveen, I'll start the question if possible. Now, during your paper, you've referenced other papers that talk about enhanced recovery after bariatric surgery, and you talked even about a meta-analysis. Can you compare your results to other published results and other published research, please?
Come here. Yeah, so if we need to compare our study with the others, in fact, the other studies have also clearly shown the feasibility, and yes, it reduces the hospital stay, it reduces the pain. But what is most important is just not the outcomes, but it's the processes that needs to be done. So if you ask our study compared to the other two randomized control trials that have actually been published, we are able to define what needs to be done in the ERAS pathways from the preoperative setting, intraoperative setting, and the postoperative setting, so that these are steps that can be followed. Because the intent of this paper was just not to show the medical community or the surgical community, yes, doing this, I can send my patients home. But yes, take-home messages help them in defining the processes so that they can be followed, because certain processes is not applicable in all these centers. Maybe every center may not have a tab block that can be possibly be done. In fact, in many centers, the anesthetists are not willing enough to take a clear liquids 2 hours prior to surgery, or give a carbohydrate loading 2 hours prior to surgery, or willing to give a restricted fluid therapy. So our paper tried to primarily help surgeons or the anesthetist or the entire bariatric team to define what needs to be done so that they can possibly follow in their practice. So that was the primary aim of this paper that we tried to define.
Thank you, Dr. Praveen. So I've got a couple of questions from Dr. Himpins. Thanks for joining us, Dr. Himpins. His first question was, how do you measure hospital stay? So in your paper, you reference 1.36 days. What does that mean?
Okay, so that is the time when the patient has met the discharge criteria. I think I've actually mentioned to you the discharge criteria. So when the patients meet the discharge criteria, which is if they're having adequate pain relief without the needing of a non-opioid analgesia, there is no wound-related complications, the patient is tolerating 1 liter of liquids, and the patient is ambulatory, and the patient is not as the vitals are normal, then we define the patient has met the discharge criteria. So this is the discharge of the hospital stay that we try to document. Because why I'm making this very clear is that we come from a country wherein the room charges for staying a day more isn't really very expensive, and culturally patients think staying more in the hospital is much more safer for them. So there are many times patients happily say, doctor, I will possibly stay for another 2 more days and go. I feel more safer here. I feel more comfortable here. Now, if we start taking those as hospital stay, then that was a confounding factor that will give us a different outcomes as such. Now, these are patients that they are clinically ready to go home, that they can be discharged. However, the patients might stay longer depending on their personal preferences. From the hospital standpoint, the discharge is clear. So that is what we call the hospital stay, and that was what was 1.36 as against 1.9 in the standard group pathway, which we have published in the paper.
Okay. And Dr. Himpins, the other question he's asking is, as we all know, the majority of the pain that comes, or the most painful part of laparoscopic sleeve gastrectomy is the extraction port. Do you have any tactics or any techniques that you've managed to develop or work on to try to get rid of this problem during laparoscopic sleeve gastrectomy at your unit?
So the extraction port is possibly the most painful port, and significant amount of pain is actually complained by patients post-operatively from that port, especially in centers wherein, including me, I think most of us do it, we close the ports. So actually that closure of the ports actually gives much more pain compared to the other ports. So basically, many of us earlier, when we used to do, like in the standard pathways, what we used to do was, once we extract the ports, extract the specimen, we wash the ports well, and then we try to give local infiltration of bupivacaine into the port, and then we bring it. But then if you actually really speak with the anesthetist, the local anesthetist needs anesthesia needs to be given before the trauma is created, because if the trauma is created, the blood clots happens at the neuronal level, the drugs really don't go work and act. So if you need to give a local injection, it needs to be given preoperatively. But instead, now what we have tried to do is, it is usually between the T6 and the T10 is where we will put our the 12 mm port for the sleeve, and where we'll be extracting it. So that is what is addressed by a tab block, and the posterior block or the 4-quadrant block addresses that part. And when we are trying to close the ports, we try to always completely, it is done under vision. We need to make sure we do not go more than 3 or 4 millimeters beyond the cut end of the sheath on the superior and the inferior aspect, so that the amount of sheath on the muscle that you tie it over should not have any kind of a nerve entrapment. The more you take, the more the pain, the lesser you take, lesser the pain. And this is addressed even pre-operatively, in the sense before the incision is actually made. So if we need to address the pain, we need to give local infiltration or a tab block or a 4-quadrant block before the actual incision or the port is done. And of course, we also try to give preemptive analgesia post-operatively. We don't wait for the patient to actually experience the pain, ask for us, and then we try to go. We need to preempt. So kind of preemptive kind of an analgesia is very important in the post-operative setting.
Thank you. Dr. Hemplin's still insisting on what does 1.36 days mean. Can you give us, can you elaborate more? What do you mean by that?
Okay.
So have you just basically measured the number of days and divided them and you took the average? What does that mean?
Between end of surgery, between the time between the end of surgery.
No, I'm not getting the point. The point is, how was 1.36 calculated, right?
No, as in what does that equal to in real time, if you know what I mean? Because it is 1.36. If it was like out of 100, we understand it's 336 out of 100. But out of a day, 1.36, what does that mean?
So that is the mean.
That is the mean. That's what I thought, to be honest. Okay,
Okay, that is
fine.
That is the mean. So the hospital stay was between 1 to 2 days in the ERAS group, and it was between 1 and 3 days in the standard group. When you put the mean, it was 1.36 plus or minus 0.56. In the other group, it is 1.89.
I get you. Okay, there's a question about.
That was the question. Okay.
I've got a question from Zahra Fatou. Thank you, Zahra, for your question. And then she talks about, are you worried about restricting the fluid and increasing the risk of thromboembolic complications? Is that something you thought about or not? And how did you manage to negate this risk?
Okay. So I think the fluids, restricting fluid therapy, it needs to be a demand-based kind of a fluid therapy. Generally, the anesthetist, to reduce the overall risk, have a preference to use, in fact, my anesthetist is actually sitting beside me, tend to use a liberal fluid therapy in all these patients. But many times, these are morbid obese patients where there is a lot of third spaces loss. And these third spaces losses kind of cause a kind of an anasarca, and also helps in it delays the post-operative recovery. So it is actually a very fine line. We should not be over giving fluids or restricting too much that can potentially cause a dehydration that could increase the thromboprophylaxis, or that would increase the chance of a DVT and a pulmonary embolism also. So it is a very fine balance. So this restricted fluid therapies means it's basically a judicious approach wherein you need to maintain not like a negativity, neither a positivity, but a near zero fluid balance. So that is what is very important. This also helps in reducing the post-operative ILS, hence by increasing patient outcomes also. So it should neither be on the negative side or it should be on the positive side. But as you've already mentioned, we as a center also have a very strict thromboprophylaxis policies in form of mechanical and chemoprophylaxis we give thoroughly in all our patients, starting from preoperatively and a minimum for 7 to 10 days postoperatively in low risk patients and 4 weeks postoperatively on high risk patients. So it needs to be judiciously calculated, because at the end of the day, doing too much is also not good. Too low could be dangerous.
Okay, I've got a very interesting question, and I think it's a clever one from Sophia. We know the importance of patient education, involving the patient in preparation to be involved in or engaged with the enhanced recovery. But as correctly she said, you need, and you said actually the same, is you need the team. So what is it that you do to keep your team engaged, committed, and enthusiastic about your approach?
Yeah, it's quite, in fact, scientific questions are easier to answer.
Agree,
so basically,
agree, but it's a clever one.
Yeah, so I think at the end of the day, with regard to bariatric surgical practice, let's leave alone any other division of surgery. I think a bariatric team, your outcomes of the patient is probably directly proportional to a motivated multidisciplinary team that you have. You could be the great surgeon doing a great sleeve gastrectomy or a Roux-en-Y gastric bypass, but we could get pathetic results. I'm just not saying about the recovery in the early recoveries, or I'm saying even in the long-term outcomes, in reducing your nutritional complications, reducing your weight regains. Even in these setups, I think a dedicated team who's focused towards is very important. So I think, first of all, each member of your team needs to realize that their role is not in helping the doctor, but their role is in helping a patient. They are working for a patient. If I keep, generally in any surgical team, the surgeon becomes the center of the team, surrounded by everybody. But if we can make our team realize that the patient comes in center of the team, I mean center of the entire team, surrounded by all of us, and surgeon only in one corner, if they feel it from inside, then they will start working towards helping a patient to recover early, go home early, counseling them, making sure they're following up, calling them up that the follow is maintained or not maintained. So they try to create a family kind of a culture wherein you keep your team motivated, wherein they have to realize a coordinator is not somebody low compared to a surgeon. The case manager or the patient manager is not somebody low. Everybody plays an equal role. If we can get this within the heart of each of a team member, if they start realizing they are as important as you, and if you start realizing they are as important as you are, then possibly I think we would be able to give the right outcomes in a patient, is what I think. Maybe I'm not sure whether I answered your question properly,
No,
but
I
this is
think
what I really feel.
I mean, one of the things that we all experience, I think if you treat all members of your team with respect and give them the responsibility towards the patient, that we all are involved in the care of this patient. There is no boss and follower. We all are part of one team. That makes them feel that this work belongs to them and they take pride in it. I think you've answered it really well. So I've got another question from Perimala. Thank you very much for the question. And she's asking about, did patients have any problems tolerating fluids in the post-operative period? Is that something that you've come across during your study? I can see you've got your tactic of giving them the hydrocortisone before the surgery. Did that affect a lot the post-operative tolerance of fluid?
Yeah, we have still had difficulty. If you actually see, the one of the factors that did not achieve statistical significance when we compare the standard and ERAS pathway was the post-operative nausea and vomiting, which was roughly about 10% in our patients in the post-operative setting. So this tolerance of liquids in the immediate post-operative setting, we do find some difficulty in some patients, irrespective of this cocktail of drugs that we try to use and give it to them. But then I think, again, this is it's partly functional, it's partly physical. So again, a good counseling in the preoperatively, telling them the story goes like this. Before we actually give an injection to a kid, if you tell them it is going to be something very big, then when we expect it to be smaller, they'll say, oh, okay, I thought it was something bigger. So if we can actually tell the patient, you might have some nausea, you might have some vomiting, but we will be forcing you to give liquids. Psychologically, they actually feel better because they say, oh, the doctor told me earlier, the coordinator told me earlier. They tend to tolerate better. But then still, yes, tolerance of liquids in the immediate post-operative setting continues to be a challenge, at least in about 10 to 15% of our patients.
Okay, I've got another question from Sue Benson Davis. Thank you very much, Sue. Sue was asking about the preoperative diet, the very low-calorie diet, which you put your patients on a week before the surgery. She wants more elaboration about what does this diet consist of? Is it solids and liquids? Is it just diet only? If you can give us more information, and whether you recommend 24 hours of clear diet prior to the surgery to make sure that you've got an empty stomach at the time of the operation.
Okay, so this is a preoperative liquid diet. Initially, we used to be doing, of course, we have a lot of studies up for 4 to 6 weeks, which is absolutely not practical. In fact, 2 weeks was something we initially were doing it on a whole. We have a lot of data that supports the preoperative liquid diet, helps in postoperative outcomes, and also understanding the compliance of the patient also. So both these are the two factors which helps. And of course, it helps in shrinking of your liver, shrinking of your omentum, so that making your surgery much more easier, especially if you're handling a super obese or a super obese patient. So we follow a low calorie diet of about 600 to 800 calories preoperatively. We do not use any artificial feeds. It's a purely liquid diet, which is natural. It could be a combination of tender coconut water, porridges, soups, buttermilks, juices without any added sugars as such. So this is what we give. We also give them a high fiber supplement which is mixed with water and taken, because many times these patients, when they're on liquid diet, tend to run through constipation, either in the preoperative setting or the immediate postoperative setting. So high fiber supplement which is mixed with water and taken is what is given. This is for about at least 7 days religiously preoperatively. For diabetics, we have a very close watch, because many times we do not want the patients to get into hypoglycemia especially. So that is something we need to closely watch. In the preoperative, in the immediate preoperative day, again, we do not put them on a clear liquids as such. They continue to take liquid diet for 8 hours prior to surgery. It is only after that, in the last 8 hours, about 6 hours, they are changed to clear liquid diet until 2 hours pre-surgery as such. So then, because liquids emptying time is quite fast, so 8 hours of changing them to clear liquids is good enough. And then you can continue clear liquids until 2 hours prior to surgery also. But as a routine, many times these patients could be diabetic, some gastroparesis possibly could be there. Immediately after, during the start of the procedure, we get in a nasogastric tube. We empty the stomach completely of any liquids or any air, especially so even from a technical standpoint, if you can direct the nasogastric tube towards the fundus, suck out all the air, your dissection of the posterior fundus makes it much more easier, especially when you're dissecting out the left crus and the gastropancreatic attachments where you could find the posterior gastric artery. The surgically also it becomes much more easier. So this is something that I would do in all my patients.
Great. Okay, I've got a question which might be for your anesthesiologist more than you, and it's coming from John Herrera Koch. He's talking about, have you got any experience with other regional blocking techniques like intercostal blockage techniques and something called the Brilma technique?
Sorry, can you repeat the last one?
Brilma technique.
Brilma.
Have you tried any other regional blocking techniques other than the tap block in case there's a challenge because of a patient being obese?
No, we do not have experience with intercostal block and the other block. In fact, I'm checking with my anesthetist. What we've been doing is the subcostal block and the posterior block. There's another thing called the rectus sheath block, which is a kind of a block that's given between the rectus muscle and the posterior rectus sheath. Of course, we have tried that. We did not find much use. There are some data explaining that, but these two are the blocks that we normally do. We have not tried the other kinds of blocks.
Yeah, thank you.
And there's something called the erector spinae block, which is also not needed in a bariatric surgical setting.
Okay. And what about shoulder tip pain if you're doing hiatal dissection, Dr. Praveen? Is that something that you've come across, and have you got any advice or techniques to manage this problem?
In fact, more than me experiencing with the patient, I have experienced it personally when I have had a laparoscopic appendicectomy. So I walked to my surgeon. I actually shouted at him telling, did you release the carbon dioxide well? Did you leave some carbon dioxide? I'm having significant left shoulder pain. What did you do? So this is a bad experience that I have personally had. Yes, it's a quite bad thing. So I think the diaphragmatic irritation, because the shared nerves are the diaphragm, the C2-3. So basically, as I've actually mentioned, wash after the end of the procedure, a good thorough wash to remove all the blood clots, even if they are little. That's very important because that reduces the diaphragmatic irritation. That's the most important thing. Then we need to religiously make sure all the carbon dioxide, although they would get dissolved in a short time, then if you can religiously release all the carbon dioxide after your surgery, make sure it's all completely emptied, open out all your pores so that no carbon dioxide is left behind. So these help preferably in reducing the pain, and also usage of this dexamethasone. Also, there is some data that helps in reducing these kinds of a left shoulder pain that can be done. So these are some maneuvers that I do. So on a practical basis, me seeing the referred shoulder pain is probably very, very, very low. Although I have had it, but my patients have not had it. So.
And Dr. Praveen, have you got any experience when putting the tap lock? Because some people do it at the time of the laparoscopically. Is that something you've tried or not?
We did try, but then when you do under laparoscopic, after you have put the ports, then we're trying to infiltrate it under vision, because we are going between the internal oblique and the transverse abdominis. So basically, internal obliques and transverse abdominis, you cannot be, because it needs to get into that plane as I had shown in my presentation, which is very approximate when we try to do it from outside before we put. So I've not been very happy doing it under laparoscopic guidance. So after induction is done, it is at this point before the surgery, before we put up ports and we start, it is between induction and our surgery, we get this done by the anesthetist. So doing it post putting my lab ports, I've really not been very happy because of the accuracy of these infiltrations. Although many surgeons I know do it, but I've not been personally happy about it. And ultrasound has a very good precision if you are experienced to get it done.
I get you. And more, talking about experience, you're an experienced surgeon, Dr. Praveen. You can standardize your care. Where do you see the role of enhanced recovery for surgeons who are on their learning curve, where the technique is not as polished, the operative time is longer? Is there room for that for such surgeons?
In fact, I would say, especially in the learning curve when the operative time is going to be longer, the need for enhanced recovery pathway makes more sense. Because at the end of the day, these maneuvers or these protocols would try to help in some way or the other the increased operating times that you have. Not having these pathways, and again, you are doing a longer surgery, then putting in drains, there could be more bleeding, etc. We're actually, worsening the recovery of the patient. Now, at least doing something that can be easily done should be done. Yeah, yes, the learning curve, surgery, learning through it may take more time, but the other things of counseling, restricted fluid therapy, giving the appropriate drugs, post-operative pathways can be done right from day number one. Maybe if your anesthetist is also not experienced, not very confident in this, it's fine. But I would say in these pathways, what all we can possibly can, I think we should try to adapt to that. But then doing one thing and not doing entirely, then again is really doesn't make sense. It is actually driving on the road. If you need to follow the protocols, you need to follow all the protocols. But for young surgeons, my advice is try to do as much as you can from case number one. It will help your patient. At the end of the day, patient recovery, reducing their morbidity, their outcomes is probably most important. Even if they have to go through the learning curve, they need to have good outcomes in the beginning. Only they'll have a much bigger learning curve and the times to come.
Fantastic. Now I have a question of my own, please, Dr. Praveen. You know, when you standardized, you had the control group and you had the study group, but all your patients within the control group had an NG tube and the study group did not have an NG tube. How did you manage to keep the blinding of the study with this confounding factor being there?
Okay, so with regard to the protocol, the principal investigator and the surgeon is not blinded. So in the post-operative setting, it is managed by the staff who will be entering the pain scores in the ward, whichever ward they are. They are completely not aware of any kind of a study that's on, whether this patient ERAS group. So they have not been familiarized with the protocols of the study at all. So they were the one, they will be documenting the necessary information on the thing. So which will be extracting the information to us. So they are obviously blinded because they are not aware that one pathway will have an NG tube, one pathway will not have an NG tube. So that kind of a confounding effect will not be there because they are blinded because they are not aware of the protocols that are in place.
We get you. Okay. And there was another question from Anand with regard to the wash that you use. Is there a certain volume that you use, or it depends on how much you need?
There is really nothing specific. Basically, at the end of the procedure, we have this irrigation apparatus. We try to flush normal saline. So we would want to make sure the aspirate that we're going to get back is going to be as clear as what we injected. So if it is going to be red, then when we flush it again, we irrigate it again, then we remove it. If it is still pinkish or mild reddish, then we give it again. We make sure the aspirate is the same color as what we injected. So we are making sure there is no blood or any kind of fluid that is left in place. So that is there is no fixed volume as such. The volume that is needed to get this process done.
I have a question from Mahesh from Bangalore, and he was asking is if you come across a situation where you've got this patient that is not keen to go home, what sort of conversation you will have with them? Because you and I are probably going to come across these individuals quite often. Have you got any things that you could utilize, any tactics, any ways of talking with them? Have you got a certain team member who's quite good at convincing people?
No, you mean to say for the for getting the bariatric surgery done or for getting the discharged?
For discharge.
Okay. So yes, this is something we very often see in our practice because as I've told you earlier, unlike in many of the Western countries, the stay in the hospital for another additional day or two isn't really very expensive compared to the surgical procedure as such. So technically, patients also believe being in the hospital actually gives they believe gives them more security because they are under the supervision of the surgical team, so they can make sure everything is all right. So this is a psychological feeling that the patients have in general. This is in general. That is why India as a whole, the concept of daycare surgery, of course daycare is something different to ERAS, really did not pick up big in India at all. The concept of, if you really ask me, there is daycare surgery is hardly done in the Indian subcontinent, the 23-hour discharge as what we call, because patients do not want it, because the more in the hospital, they think they are safe. So this is why this preoperative counseling is very important. So we try to sometimes even fear them. Staying too long is really not good for them. There are other patients who potentially give them the infections. Being in the hospital, they will be moving around less. The chance of they getting a deep venous thrombosis is much higher. And then we also tell them, whatever we tell them preoperatively works well postoperatively. Something that is not informed them preoperatively, if you try to explain them postoperatively, it is usually not taken up very well by the patient. If you can tell the patient preoperatively, you will be fine to go home in the POD number 1. We would be sending home, making sure you're absolutely all right. Of course, we will make sure you're also pain-free and comfortable, but be ready to go home on POD number 1. So they are ready, waiting for the doctor to come to the room and tell them, yes, you can go home. Otherwise, when we go on POD number 1, tell them, do you want to go home? They say, no, I will stay for a couple of more days. And I personally believe the patient does not want to go home, we shouldn't be sending them home. I think it's something, patient's confidence is something really very important. So we really don't try to do any tactics to push them out of the hospital postoperatively if they don't want to.
Dr. Praveen, do you have access to home care or support at home should the patient need any, if they want to go, or they're not keen to go home or reluctant to go home? Is that something your hospital provides or no?
No, we do not give a home support as such. Of course, we give them good virtual support. So whatever need be, they can get in touch with us through any of these virtual platforms. And we do have centers in at other towns and cities also. As a hospital, we have, this is a hospital chain that we have hospitals in other places also. So in case they have any difficulty, they have trouble once they get back home, we would request them to visit one of a neighboring facilities. So we will get in touch with them, even appropriately managed, but we do not as a policy do home care or home visit in those regards.
Okay. Now, as we are in the era of COVID, has this pandemic, I'm not sure if you're continuing to do elective surgery or not in the first place, but has this pandemic changed or altered the way you practice your enhanced recovery program, Dr. Praveen?
Okay. In fact, since the COVID pandemic is on, we are still, as a part of India, is in a lockdown called Lockdown 3.0. So that is where we are in. So there is a kind of lockdown plus restricted movement outside. So we are gradually starting our elective surgeries. So bariatric work, we've just started. So I think the concept of enhanced recovery makes much more sense at this point of time, because we want the patients to be in the hospital environment as least as possible. So now this concept will, because the more they're in the hospital, the more the risk for them and for the healthcare workers. So in this regard, I see enhanced recovery pathways to make much more impact at this point of time. And I also see patients taking up the concept of daycare with enhanced recovery pathways attached to it much more, because they also want to be in the hospital for the limited point of time. So I think this COVID era will probably help the boon of daycare procedures in a country like India, and ERAs will make much more sense.
And have you been using teleconsultation in your practice?
Yes, we have always been using our own teleconsultation module, always. But again, it made more sense once the COVID pandemic started. It made more sense because what we had the system in place, and we've started. And I think no better surgical department than a bariatric surgery follow-up, wherein the teleconsultation will make more sense. Yes, I think it was a great boon. The teleconsultation really helped us in making sure we follow up our patients really well.
Thank you. I have a question from Hatem Asadi talking about the follow-up. When do you see these patients for their first post-operative visit, Dr. Praveen?
So our protocols go like these. So from the time of discharge, considering the patients are in a locality that they can visit us comfortably, I mean, they should not be from a very, very, very far place or a different country. Considering they are within my zone, the first visit be in the post-op day number 15. So the reviews will be, the normal reviews are post-op day numbers 15, 1.5 months, 3 months, 6 months, and 1 year. So this is the fixed protocol that every patient has to follow. If the diabetic patients, they tend to maintain a sugar diary, what we call it. So they would be documenting on a diary and sending to us the charts every 7 days for us to understand where it's going, so that we can titrate the sugars. The review, the question goes for after 15 days, which is 2 weeks.
And when you see them after 2 weeks, is that an actual visit or a teleconsultation?
No, we prefer as much as possible an actual visit. Televisits are for patients who will not be able to visit to us after the 15 days for physical reasons or logistic reasons. But considering there's no COVID pandemic, we prefer a physical visit as much as possible, because the thrust that we can give, or the emphasis we can give on the dietary management, on the physical workouts and the psychological management, I still think virtual consultation is still inferior compared to a physical consultation, purely personal.
No, I don't know. I mean, I agree with you. It is a personal opinion, but I think the first visit or two after the surgery are crucial to be actual visits. You physically assess the patient, see their wounds, make sure they've got no acute problems. Dr. Praveen, in your study, the average BMI was in the early 40s. What is your selection criteria for the surgeries that you offer your patient? Is that BMI what decided them to have the sleeve? What is your algorithm in deciding what surgery is suitable for what patient is?
Okay. So our protocols go like these. Of course, patient priority takes the first stance. If the patient comes with an educated understanding the risks and the benefits of a particular procedure and is very clear about that particular procedure, we try to offer the same, making sure there is no contraindication. Otherwise, our protocols are like, if the comorbidities, because India is a diabetic strong country, if the comorbidities, especially diabetic, is quite severe in the sense requiring insulin therapy, HbA1cs are more than 8, C-peptide levels are on the lower end, or if the dyslipidemic status is quite poor, then these patients, we would prefer a bypass procedure, preferably a Roux-en-Y gastric bypass. So this will be a choice. Any patients with a severe physiological GERD, GERD, which is proven, or in doubtful conditions wherein the pH study clearly shows the D-Meester scores on the higher end, they would only get a Roux-en-Y gastric bypass. Third, patients, we have published one of our studies where we have compared patients above 50 years of age, where we have compared sleeve versus the bypass. So more the elderly patients, but nutritionally well maintained, we prefer a Roux-en-Y gastric bypass, because we had significantly better outcomes with Roux-en-Y gastric bypass over a sleeve in patients who are elderly as the age goes above 50 years of age. Otherwise, again, with regard to the BMIs above 50, we try to prefer a Roux-en-Y gastric bypass as much as possible. Although BMIs above 70, we would choose a sleeve as a first stage operation. Remaining all the patients, preferably it would be a sleeve gastrectomy. I mean, this is in general.
Okay, so Dr. Praveen, as a message from you to any starting surgeon trying to implement enhanced recovery to their practice, can you talk us through the challenges that you've had, talking about the cultural challenges, the mentality challenges of the team, the paradigm shift that you needed to implement to your team? Can you talk us through that journey, what challenges you went through, and how did you manage to overcome them to get to where you are now, please?
Okay, so before we actually started the trial, we actually wanted to know what challenges we could possibly have. So we actually did a pilot study of 25 patients, because where all we could have a possible difficulty. So this was the first step that we did. The major areas that we had difficulty were convincing our intensivists, because the patients immediately go for the first 4 hours to the recovery room, which is managed by the intensivist, telling them, I want you to give my patients liquids in 2 hours time. I would want you to start ambulating my patient in 2 hours time, which is something they were not doing for the other patient. That is not the protocol. They let the patients rest as much as they can. Liquids are not really hurried up. So that was the culture, because ours is a completely GI surgical center wherein a lot of upper GI work in the form of total gastrectomies, esophagectomies, or Whipples might be happening. So this was something they were being handling. When I went to them telling I would want this, there was a lot of time. It took a lot of time for me to convince them we could safely do this. Then the second part of it was counseling my team to counsel my patients on the postoperative pathways, exactly making our patients understand, because as I've told you earlier, the understanding of the patients is very, very, very important. Then the third thing is establishing a pain pathway and making sure the follow-up is done exactly, because many times we leave the patients to the ward. We would be giving some painkiller. The ward nurse or the ward duty doctor might be calling us, telling, so the patient is complaining of severe pain, what what can I do? Then you might give him an advice, oh, you maybe give that, or you maybe give that. So I think we need to be preempting. We need to be closely following up with the patient to understand. So we need to counsel our team telling, do not wait for the patient to come back and tell you having a pain score of 7, then try to give them an analgesic as such. Work with the patient, talk to the patient, try to understand, try to preempt, try to give preemptive analgesia. So these were the certain areas, and of course getting your team in together, because many times in many hospitals there are different set of anesthetists who come for your surgery. They might keep changing every day, and this anesthetist may not be a pure bariatric anesthetist. He might be doing different work every day or the other, so he may not be ready to try certain aggressive things like this restricted fluid therapies, etc. So he would want to make the patient sleep well, comfortable, give high doses of everything, and then relax. So you need to find like-minded anesthetists who would work with you in tandem for all your patients. In fact, your role of your anesthetist doesn't stop only during surgery. He needs to be with you even in the post-operative setting, meet the patient post-operatively, monitor the pain scores, understand how can he improve his anesthesia. So I think forming this team from your coordinator to yourself, to your anesthetist, to your intensivist, your post-operative staff, pain nurse, and all this matters. And I think the first 25 cases helped us learn, so that accordingly we were able to design this trial. So I think again here, just the message that I will give to a lot of young surgeons is that I think being a good heroic surgeon is not enough. You need to have a very heroic and a like-minded team who are ready to work with you.
And I think the message is spot on. But have you had any team member who you found a bit of a challenge to get them on board? Because as you know, with the ERAS, anesthesia is crucial. It is as crucial as surgery. Surgical technique is one half. ERAS is anesthesia is the second half. Have you had any special training for your anesthesiologist to get them on board? What is it that you did?
Okay, so when basically the whole thing started, in fact, my anesthetist is actually sitting with me right now, Dr. Prabhakaran. So he actually showed interest in bariatric anesthesia. So basically over the years, so this was an understanding that we built over the last 5-6 years easily. So when we started off, normally when a regular anesthetist will look at your for a normal anesthetist, every obese patient is a high risk patient. They look at somebody obese, they say, oh, it's a high risk. Why? Because it's obese. Because obese patients have so many comorbidities that could possibly come. So you first need to make them understand that obesity anesthesia is a specialty, similar to cardiac anesthesia, similar to neuroanesthesia. I think bariatric anesthesia is something important. So for a cardiac anesthetist, even all the 3 vessels are completely blocked, he's fine. Yeah, because he's always seeing only blocked arteries. But for a normal anesthetist, even a one vessel is blocked, he's like, oh, it's a coronary artery disease patient, it's a high risk patient. So they need to first start getting the understanding, yes, obese patients are now normal if you start specializing into it. So when you start guiding them, you start working in them, yes, you fight, you argue, you start doing it. Then if you can get this one person who will be with all your patients, that is something which is from a management standpoint, you need to work with the management. Luckily, we were able to work with the management, make sure we have one anesthetist as part of all our programs. We were able to do that. So I think that is something you need to work. And if the management or the working culture decides that you cannot set that, I think it's not going to happen, because anesthetists and surgeons becoming friends is like a husband and a wife relationship. It's quite a tricky job.
Okay, well, Dr. Praveen, it's been really interesting talking to you. I think we could spend hours going through this topic and going through the questions. Any last messages before we conclude this interesting journal club?
Okay, so I think I just want to make the comment of, because when this paper was supposed to be published in obesity surgery, you have the reviewers' comments. You know, one common comment that we had from all the reviews was that 1.3 versus 1.9, so it's just half a day of difference. Is it really is it really big? What is really a paper trying to achieve was a question that almost all the reviews asked me. So I would like to answer that telling in fact, I had actually said this at the end of my talk. The intent is not to show that we can send the patients home by half a day earlier. That is not a big difference. But yes, when you have protocols in place, it is not these straightforward ASA 1-2 patients that you can send them home earlier, but having protocols and systems in place in a multidisciplinary manner, you will make your ASA 3 or even the higher end of ASA 3 patients, which your anesthetist might say, oh no, this is too high risk, let's not touch this, let's not do it, do this, do that, wherein people do not want to really do, where this is referred to higher centers, etc., where therein you will be able to just show the outcomes. These patients will recover just like your normal ASA 1-2 patients, because that is the major thing that we can see. That is making your higher risk patients have less morbidity and go home earlier is something that's very important. So the role of ERAS is just not about sending patients home, but improving their physiological and psychological recovery. And this will also give them, because at least in bariatric surgery, patients bring you patients. The attitude towards surgeries itself will change. For them now, coming and getting a surgery done is just like going, and it's like a cakewalk or going to a picnic and coming back. We can tell them surgery is not what it used to be. Surgery is now something completely different. You will enjoy the entire process. We will make sure that it's enjoyable. In that regard, this ERAS pathways, this paper is very close to me, because, and I again want to come back with application of ERAS pathways on ASA 3 patients is what I'm trying to work at. Hopefully I'll come back with more data.
Your message is loud and clear, Dr. Praveen. Thank you, really, thank you very much. I truly enjoyed this journal club. To all of you who've joined us or have joined halfway through the presentation, I would like to reassure you that this presentation has been recorded. It will be uploaded to the IFSO Virtual Academy and the IFSO YouTube channel, so you can always catch up. Please keep the questions coming. Use our social media platforms. We can always pass your questions to Dr. Praveen and provide you with the answers. Thank you all for the opportunity. Thank you for joining us. Keep well and God bless. Thank you.